Good morning, everyone. We're going to get started. I am very excited for this session as today we have two fantastic clinician leaders and educators from Parnassus to share cases from UCSF Health. Dr. Bryn Boslett will start us off. She's an associate professor of medicine in the UCSF Division of Infectious Diseases, who's the medical director of the 360 Positive Health and Wellness Center, a medical home for people living with HIV at UCSF. She's also an associate program director of the medicine residency and works clinically in inpatient ID and HIV primary care across the city. Dr. Monica Fung will follow Dr. Boslett's talk, and she's an assistant professor of medicine in the same division, who is a clinical associate director of the immunocompromised host infectious diseases program and leads the transplant and immunocompromised host track within the ID fellowship. And she also works clinically in inpatient ID as well as HIV primary care and outpatient ID. So we are thrilled to welcome them to go through a couple of very interesting cases from Parnassus and transplant in HIV. Thanks so much.
Right. Thank you so much. And let me just see, I think I just look here for my slides, right? Okay. Yes, no problem. With these? Okay, perfect. Okay. Hi, everybody. Thanks so much for coming out despite the rainy day. I love seeing everybody, and welcome to people who are also attending online. So I'll go ahead and get started. So learning objectives, I'm hoping that at least by the end of my session, you'll be able to describe a differential diagnosis for skin, bone, and pulmonary lesions in patients living with HIV. So I'll have the first case, and then Dr. Fung will have several others. So this was a patient who I saw in the fall, 35-year-old man with a history of well-controlled HIV. His viral load was undetectable. T cells were in the high 200s. He was on Biktarvy, and his HIV had been well controlled for years. Also a history of bipolar disorder and migraines. His story started in June when he went for a PCP visit. He was complaining of a couple of weeks of an intermittent focal right-sided and non-positional headache. He denied a number of different red flag symptoms such as neck stiffness, nausea, vomiting, and head trauma. He had a normal exam, including a neuro exam. So his doctor thought that this was most likely related to his migraines, gave him a prescription for sumatriptan, and gave him some return precautions. Then in August, which was about 2 months later, he presented to his local emergency department with persistent headaches that were worsening. And plus, he had the onset of these unusual skin lesions on his scalp that had started about a month ago and had been growing. He also complained of a mild cough that was non-productive. He denied fevers, chills, weight changes, nausea, vomiting, and vision changes. And his vital signs, again, were normal. And his exam was actually quite normal, including a neuro exam outside of these unusual skin lesions, which I have some pictures of here. So you can see probably the largest, most prominent lesion was on the center of his forehead, and it looked kind of ulcerative and just not looking so good. And then he had several other lesions on his scalp with sort of a punched out appearance that you see here. Other pertinent history. So for his medications, he only was taking Biktarvy on a regular basis. He had a family history of breast cancer in his mother, hypertension in his father, and type 1 diabetes in his brother. He had a prior history of tobacco and methamphetamine use, but he was no longer using either of those. He rarely drank alcohol. He was sexually active with men and women, and the last episode was about 3 months prior. He was born in Sacramento and still lives there with his parents and his brothers. He's unemployed at the moment, has no regular partner. He had no really interesting exposures. He denied water and other outdoor exposures. He did have some animals, cats and dogs, but they were mostly indoors, and they were in regular veterinary care and were healthy. He didn't have a lot of exposure to other animals. He denied any recent travel. He had never lived and never traveled outside of the country. He had no clear tuberculosis exposures, and he denied eating really any interesting foods, but specifically no unpasteurized foods or soft cheeses. So in his local emergency department, they did a few tests. Of course, they did a COVID test, and that was negative. They did a CBC and BMP, and those were normal. His LFTs, interestingly, were slightly elevated. The team there had wanted to do a lumbar puncture given the headaches that were worsening in a patient who's immunocompromised, but he had declined this a number of times. So they decided to go ahead and perform some imaging. And here was the first set of images. So they did an initial CT scan that showed these unusual erosive bone changes. And you can see on the left just an example of one of the changes in the parietal lobe. And this prompted them to get additional imaging with an MRI. And you can see even more findings here on the right. And I will read the findings for you. So multiple enhancing calvarial erosive lesions. They appear to be originating from the bone rather than the skin. The largest lesion extends to the skin with an area of ulceration and necrosis, and it also extends posteriorly through the inner table of the calvarium adjacent to the superior sagittal sinus, where there is a thin, non-occlusive filling defect anteriorly and mild thickening of the adjacent dura. So this looked pretty bad to people, and they were very concerned about what this might be. Because he had a cough, he had gotten a chest x-ray, which was abnormal. So they did a chest CT, and here were the findings of the chest CT. You can see most of the findings in the lungs are sort of on the right side, involving the upper lobe, lower lobe. And I also included some bone windows here on the right-hand side of the slide, because there are also some lesions within the bones of the chest. So the CT read was multiple pulmonary nodules with associated dilation of the adjacent airways, and additionally, multiple lytic lesions, most notably in the sternum and the right coracoid process, as well as in the left seventh rib. So very unusual constellation of findings here. So I will ask people to vote at this time. What do you think this could be? Is this cocci, so valley fever? Could it be a rheumatologic process like GPA? Could this be KS, Rhodococcus equi, or Treponema pallidum? Oh, okay. All right. Yeah. Sounds good. Okay. Does this sound like right time? Okay, good. All right. So I love, so nobody liked GPA. Okay. So I love that there is such a big split of people's ideas of different things going on. And I think that's how I felt as well whenever I initially saw this case. It was like, what is this? There's such a big differential diagnosis. So before I give you the answer, let me go through a few more findings on the case and see if people change their minds. So okay, so we had thought of a pretty big differential diagnosis for this case. Of course, there were many different bacterial things that this could be. You know, it's hard to ever rule out Bartonella. Could this be endocarditis with septic emboli? I mean, maybe that would explain the lung findings, but, you know, the other things, not so sure. You know, you can never count out tuberculosis or other NTMs. We even sort of discussed leprosy, nocardia, actinomyces. Rhodococcus was a choice on the last slide, as well as syphilis can do anything, right? We also thought, could this be a fungal process? Could this be PJP or one of the endemic fungi? He lives in Sacramento. Could it be cocci? Or, you know, could this be blasto because of the unusual skin findings? Sporothrix, invasive molds seemed like the wrong host for that, but it went on the differential. Parasites, we thought a little bit less likely. I mean, he didn't have much of an exciting travel history to go with leishmaniasis, but, you know, just to keep it interesting, we discussed it. Malignancy, you know, KS or something else, Paget's disease because of the bony lesions, or some unusual rheumatologic presentation. I'm always surprised sometimes with things that I thought were infectious that turn out to be inflammatory, and you never know. So the patient came to us actually at this time point for a higher level of care and to get a number of diagnostics. He underwent lots of different biopsies: skin, lung. He underwent surgery. He had a craniotomy for IND of that central lesion on his forehead. And unfortunately, we didn't actually get a diagnosis from any of these samplings. So the bone did show osteomyelitis with a pretty aggressive either infectious or inflammatory process. It was centered in the bone and had an adjacent invasion of the epidural space and the skin, so pretty gnarly. The lung lesion kind of showed non-specific inflammation, and I didn't put the skin findings here, but it was similar. It was sort of non-specific findings. There was no evidence of malignancy on any of the tissues that were examined. Cultures and stains were done. I think there were more than 20 different cultures done on all of this material, and all of them were negative for bacteria, fungus, AFB, and all of the stains were also negative. And we also sent off a universal PCR from bone and lung tissue, and those were negative. So really, like, what is this? A lot of other labs were sent looking for, various serologies for fungi, Bartonella, et cetera. And IGRA was negative. All of this kind of came back unrevealing. And then a diagnostic test returns. So his syphilis RPR titer was greater than 1 to 256. And according to the public health department in Sacramento area, he had last been tested about a year and a half prior to this and had been negative at that time. So we decided that this entire picture was caused by syphilis, which is wild, right? All right, so a bit about syphilis osteitis or osteomyelitis. It's a relatively rare clinical entity, although I think whenever we started looking into the literature, there are a lot of case reports of this, but it's really at the case report level. It's most often described in secondary syphilis, but also has been seen in tertiary or congenital syphilis. The largest case series that our resident working with us found was actually performed a long time ago. So in the 1940s in Johns Hopkins, they examined 10,000 cases of syphilis to kind of characterize the various manifestations. And of those 10,000 cases, they only found 15 cases of bone disease over a 21-year period. However, this was done in the 40s. I don't know that they were using, CT scans and MRIs back then. Additional research was done again by the resident working with us and found 50 relevant results over the past couple of years, so more modern history as well, including 18 full case reports of this entity. And what we found was that the majority of patients who are diagnosed with this are HIV infected, but they tend to have well-controlled HIV. This isn't necessarily a diagnosis of somebody with more advanced HIV. Neurosyphilis is present quite frequently. Perhaps unsurprisingly, headache is a very common feature, as well as tender scalp nodules. And of the 18 full case reports, there was only one patient who was asymptomatic and kind of discovered incidentally. And down here on the right is a picture of a skull from the catacombs in the 16th century with syphilis osteitis. So this is sort of an old disease. But this patient actually had two very rare manifestations of syphilis because he also had pulmonary syphilis. And, looking into the literature about this, it's also quite rare. People seem to love to do studies on syphilis in the 1940s, but another case series of about 1,500 patients, this one from Bellevue Hospital in New York, they actually did not find any evidence of pulmonary involvement in those syphilis cases on x-rays, but these were, old x-rays and no CT scans. So again, I don't know how good this data is. There was a CID review article in 2006 that said that they found 9 credible cases of pulmonary syphilis between 1968 and 2006. And in the past 10 years, there have been more, probably as people are getting more imaging, more advanced diagnostics. Unfortunately, radiology is pretty non-specific. This can appear in lots of different ways. It can be subpleural nodular opacities, like in the case on the top right. It can be more solid or multiple pulmonary nodules. It can present as pleural effusions in some cases. There really isn't one specific finding on imaging that can clue you in to the fact that this is syphilis. And in my review of the literature, despite numerous case reports where people had pursued biopsy and BAL and all of those different things, it's actually fairly rare still to visualize the organism in those tissue samples. Now that we have more molecular diagnostics, it's getting actually a little bit easier to find. And in the past 5 years, there were a few more cases of patients who had positive PCRs on BAL or tissue. So maybe going forward, we'll be able to utilize those tools to nail the diagnosis. But otherwise, as it stands, it's kind of a diagnosis of exclusion. Which brings me to this. I wanted to include this because it is from a UCSF physician. So this physician, Dr. Diana Lewis Coleman, and her colleagues, she was training at UCSF in the 1980s, and she actually had a case report of this, a patient who she saw in 1980s. So this even predates the people describing HIV. And she proposed a criteria for diagnosing pulmonary syphilis that included history and physical findings that were suggestive of syphilis, positive serologic tests, pulmonary abnormalities on imaging. And then number 4 really kills me, ruling out everything else, right? So not a super helpful criteria because you essentially have to exclude other likely causes. And then response to anti-syphilitic treatment that's visible on serial scans. So actually our patient, given all of the different studies that he went through during the few weeks that he was hospitalized, he did meet most of these criteria. So let me, okay, so how would you treat this patient? Do people want to give the patient a couple of weeks of IV penicillin, maybe 3 weeks, maybe 6 weeks, since this was osteomyelitis, you want to give them a little bit longer? Maybe you want to just treat with benzathine penicillin, just, once a week times 3, much like you would for latent syphilis. Perhaps that is, sufficient. Ceftriaxone, once a day, maybe a little bit more convenient for 2 weeks, or do you want to go with pills, doxycycline for a month? All right, I'll just give people a few more seconds. Okay, people vote? Yeah, okay. All right, oh, okay, so people want to go with aqueous penicillin for 6 weeks, and some people wanted to do 3 weeks, and then there was a smattering of sort of everything else. Well, I can tell you that in the 18 case reports that we found for the osteitis, that all of these different options were done. And all of them reported some degree of success on, monitoring syphilis titers and on monitoring how the patient was feeling and on serial imaging, et cetera. Many people got some combination of these things because maybe they started out in the hospital and they got some IV penicillin and then they left and, needed to get shots because they couldn't get a pick for whatever reason. And so, these things are all have data. And I think the main question in our minds was, for the osteitis or osteomyelitis, do we really need to extend to 6 weeks, or can we get away with 3 weeks or something, because some literature suggested that you could, but I was a little nervous. So what ended up happening? So this patient ultimately completed over 2 weeks of sort of broad spectrum antibiotics with ceftriaxone and vancomycin. That kind of got rolling before the patient was even transferred because people were really worried about the MRI findings and, thinking that maybe he had some meningitis and he never got an LP. And so they kind of wanted to treat that empirically. He did receive also 2 doses of intramuscular penicillin because initially, before we pulled all of this data together, we put him on a course for latent syphilis, since it had been, more than a year since he had last been tested. And so he got that. And eventually, whenever we got involved in the case, we ended up looking at all the data and saying, it seems like it's nothing else. It seems like it's all syphilis. And we transitioned him to an additional 3 weeks of aqueous penicillin, kind of feeling like all the other things that he had gotten gave us, some credit, and that, if we gave him an additional 3 weeks, that would probably be at least a solid 6 weeks of therapy. Maybe it was overkill. I don't know. He returned to Sacramento. He completed therapy there through the OPAT service at our clinic. So we monitored him remotely, but he never came back for UCSF follow-up. So we never got to see him or do any more imaging. But we did call his HIV doctor and made sure that they were going to do some follow-up imaging and trend his RPRs. And we got a MyChart check-in from him. He said, everything's healing up wonderfully, and I have a pretty amazing story, ha ha. The antibiotics were a breeze. I had virtually 0 side effects. So I think we did well. So take home points, syphilis remains the great imitator. You really have to respect this disease. It can do many things. And HIV infected patients seem to be at higher risk of more atypical syphilis presentations, even if they have well-controlled HIV. Syphilis, osteitis, and pulmonary syphilis are rare manifestations that often occur in the secondary syphilis stage, but maybe not as rare as we think because we probably aren't going around like x-raying everybody. The diagnosis is really one of exclusion. You kind of have to have a compatible clinical picture and rule out other likely things. You might be able to get away with just 3 weeks of penicillin therapy. Some people in the literature did. We didn't go that way because he had such bad osteomyelitis. And you should follow patients' RPRs and also radiographically to make sure that they are improving. So I want to acknowledge our patient, Christopher Leone, who was a resident who was working on one of these cases with us. Dan Minter, who I see in the back, who was one of our fellows involved. Aaron De La Cruz and Luis Rubio, who also were involved with the patient at various time points. So I'll stop there.
Wow, what a case. Thank you, Bryn. Yeah. No questions from the online audience at the moment. In-person questions. I see a couple. Okay, I'll start with Peter.
Hey, Bryn, that was great.
Hey, yeah.
I was really struck by the comment you made that in these cases of pulmonary syphilis that you often don't find evidence of the organism despite such a dramatic appearance on the radiographs. And does that suggest to you that this is immune mediated? And if so, what is it about treated HIV that predisposes people to this sort of presentation?
Yeah, I think that that's a good thought. And I mean, of course, the answer is, I don't know. And possibly, I mean, what I've heard suggested is that in some of the cases where they are, doing a BAL or taking a biopsy, that if you have blood in those samples, you might even get a positive molecular result because of, getting a blood sample and actually finding it in the circulation rather than in the tissue. The tissue tends to come back, at least in some of the literature, is more like a granulomatous inflammation. We did see that on one of our samples, which freaked everybody out about tuberculosis. But we often saw most of the samples were kind of a non-specific inflammation. And yeah, I don't know, because it is majority cases of patients who are HIV infected, could it be something in their immune cascade that's going wrong here? But, there were something like 38% of patients in the case series that we had looked at that weren't HIV infected. So, I think hard to say.
That was a great case, Bryn. Thank you.
Yeah,
I was just curious, did you guys get an LP? I missed the beginning. And did you consider it? I'm just curious with that.
Yeah. So yes. So I've got to be honest with you. In reality, this was 2 cases. I saw 2 cases of this year, not one with just the bone and one with the bone and the lung. In one case of the patient who just had calvarial osteitis, he did get an LP, and he was positive, VDRL was positive, and so he got treated for neurosyphilis. This patient who had the lung findings and the skull findings refused an LP. And so we never got it, but we felt like with all the different treatments that he got, he would have presumably gotten treated for neurosyphilis.
Thank you. Any other questions? Yeah.
Hi, thank you for sharing. Just 2 doubts. Did this calvarial lesion was contiguous with the bone? The external lesion was contiguous?
Yes. What was thought was that the lesion actually started in the skull, and then the inflammation extended above and below the lesion, and so gave that sort of ulcerative appearance. And that was another one of the reasons why he got several weeks of additional antibiotics. It wasn't quite open though. And, it got debrided. They basically took all of that out in the OR. So, we thought about like, does this patient need 6 weeks of even more broad spectrum therapy? But it felt like with what he had gotten, as well as things being sort of cleaned up, probably not.
Okay. And another question is about was he able to have an ocular exam, retinal examination?
I think that he did have a retinal exam. Yes.
Okay.
And it was normal.
Oh, not normal.
Yes, it was normal.
Great.
Yes.
Thank you.
Following up on Peter's interesting question, were the radiographs that you showed, was that after he started ceftriaxone therapy, or was that during the initial diagnosis? I'm sorry, I missed the.
That was actually the initial diagnostics with the MRI and the CT scans were at his local hospital. And they ended up clinically he was stable, but they transferred him because they were like, what is this? It looks awful. So that was from his local community hospital.
Awesome. Thank you so much, Dr. Boslett. Let's move on to our second speaker, and we can take questions at the end also.
Good morning, everyone. All right. So it's an extra pleasure for me to be here. I was actually getting really nostalgic as I was walking in the door. Attending this conference in the summer of 2005 as a college intern is kind of what spurred my interest in ID. So I'm excited to present some cases from the HIV transplant lens over at Parnassus. We played a largely consultative role. So I thought I'd give a smattering of cases that kind of give you a sense of some of the questions that we encounter. So the first question is this patient cleared for transplant? We get this all the time, but I'm taking this from the lens of HIV pre-transplant evaluation, which I see most of the outpatient solid organ transplant candidates beforehand. So to start off, I'm sorry, do I have to look here for my slides, or do they? Got it. Okay. I'm going to turn a little bit. So this is a 64-year-old man with well-controlled HIV. His last CD4 count right before coming to see me was 254. He's virologically suppressed. He's on Descovy and dolutegravir. He has a history of prior skin cancer, both squamous cell and basal cell, and he has alcoholic cirrhosis in remission. And he's undergoing liver transplant evaluation, and he is consented for the HOPE Act. So his HIV history, he was diagnosed in 2013 when he presented with like acute skin infection, his risk factor MSM. He does have a history of OIs at the time, around the time of diagnosis. He had thrush shingles and KS. His CD4 nadir at the time of diagnosis was 82, but has been great. His CD4 has been greater than 200 for the last year, and you'll see why that's relevant. And he's been virologically suppressed for over a year, had some prior low-level viremia. For me, I dug deeper into his KS history. And so this is a representative image, not from him, but he had visceral KS in the setting of persistent nausea and vomiting. He had undergone an EGD that showed 6 hypervascular lesions that were biopsied and positive for KS. He underwent treatment with Doxil 3 cycles, and then had subsequent repeat EGDs that were negative. And then the most recent one had esophagitis and antral gastropathy, but no KS. So the first question is this patient cleared for transplant? Yes or no? Can they move forward? All right. I'm seeing yes, 70%, no, 30%. I like that because that's my answer too, is yes. But I always try to be really thoughtful about this because, of course, as you all know, transplant involves heavy immunosuppression. Usually with induction, we do less so with livers, but heavy induction then and chronic maintenance immunosuppression on top of their underlying HIV. So I thought I'd just go through some of the HIV transplant criteria that this is from the national guidelines from the American Society of Transplantation. So the main things that we look at are, of course, we want the patient on a stable ARV regimen with no evidence of viremia. In terms of a stable ARV regimen, we ideally want people on INSTI-based regimens, and we want them hopefully not on PI and COVID containing regimens because of drug-drug interactions. And there's actually data that patients on PI regimens have increased risk of rejection because of the fluctuation in the immunosuppression levels. There's a caveat for liver transplant candidates is because in the setting of cirrhosis, some patients are unable to tolerate ARVs. And if that's the case, they can actually still move forward with transplantation, but you want a good plan for suppressing them. Like you don't want them to, you want to have a regimen already planned for immediately post-transplant. We also want their CD4 count to be over 200 for 3 months prior to transplant. For liver transplant candidates, again, you think about in the setting of cirrhosis, there can be splenic sequestration and whatnot. The cutoff is actually 100 without a history of OIs. And then, of course, you don't want patients to have any active OIs or malignancy. And our patient actually met all of these criteria. I did want to be very thoughtful about his risk of KS post-transplant though, and looking into the literature and thinking about historically, what do we know about this? Here at UCSF, as everybody here knows, the surgeons were some of the pioneers in HIV transplantation. But an important thing to note is during the initial HIV transplant study, they did very specifically exclude patients with a history of OIs and of cancer. So we actually don't have a ton of data on this. What about what we know now? So as I mentioned, this is a HOPE transplant candidate. So he would be eligible for getting an HIV positive organ. And so we'll go into HOPE a little bit in some later slides, but for HIV to HIV liver transplant, what do we know about the risk of KS? This data came out a couple of years ago from the National HOPE study group, and they saw that among liver transplant patients, if they were HIV to HIV, so donor positive HIV, recipient positive HIV, compared to donor negative, so getting an HIV negative organ, those who got an HIV positive organ were actually at an increased risk of post-transplant cancer. So 25% versus 10%. And of those, 50% were actually either KS or HHV related lymphoma. So definitely something for us to be aware of going into transplantation. So as I mentioned, I did clear the patient to move forward with transplant, but had a very detailed conversation with the liver transplant team afterwards. Beforehand, we made a plan that if he had any GI symptoms, we would scope him basically to assess, because he had no cutaneous disease beforehand, only visceral disease. And then we planned actually post-transplant to transition him to an mTOR inhibitor as part of his maintenance immunosuppression. That can't be on this immediately post-transplant because of wound healing issues, but we did want to make sure to optimize long-term to put him on everolimus, which has some anti-cancer effect, of course. He actually got transplanted within 3 months. And so this is what's wonderful about the HOPE Act is actually these patients get transplanted within 6 months usually. And for livers, even an even shorter period. He's actually my primary care patient, and so I've been able to follow him really closely post-transplant. Not surprisingly, he had mild acute cellular rejection 7 months post-transplant. We know that HIV patients are at some increased risk of rejection. He did well after that, though. Unfortunately, in the setting of all the steroids, he had avascular necrosis of the femoral head bilaterally. And then right now, what he's dealing with, which is the main issue, is actually he's had really bad SCC of the forehead that actually is invading into the nerve and bone, and recently got diagnosed with lung involvement. So we're actually now doing this balancing act of, do we give him PD-1 inhibitors, right? Because that good data for his SCC, but that will really rev up his immune system and put him at increased risk of rejection. All right. I will just try to be cognizant of time. So the next question that we get actually is the opposite side, right? Can we use this donor? And I see some of my transplant ID colleagues in the back. I've had many discussions with people about this. So still thinking about from an organ transplant standpoint, I get called a couple of weeks ago because there is a living donor, 46-year-old man, pretty healthy. He actually had previously donated a kidney and had recently had COVID infection, but was cleared from that. And he's planned to undergo anonymous partial liver donation. So as part of their pre-transplant workup, they do their usual donor screening. So 9 days prior to donation, his screening HIV EIA returns reactive. They do their usual, they send the blood out for testing at the American Red Cross, and this returns 2 days prior to planned donation, and the EIA is reactive. It's the same assay. They don't have a signal to cut off ratio available. The differentiation assay is negative, and then they do a combination NAT for HIV, Hep C and Hep B. That's NAT negative. So then the question comes to me, the additional information. Of course, the donor is a super busy person. He is traveling right now, so he can't get to a lab. So you can't get any additional testing right at this moment. The transplant is, of course, scheduled on a Friday before a long weekend and first thing in the morning. So if you cancel it, it can't be rescheduled for weeks to months. So you have to make a decision. There's a patient with liver disease waiting on the other side. Can we use this donor? This is the question. Okay. I'm seeing most people are saying yes. About 2/3 yes and 1/3 no. And I'll say we did end up using this donor. I was very nervous about it. Our whole group was pretty nervous about this, but we did. And so let's just go through a little bit of the history behind HIV and organ transplantation. So in terms of the history of HIV testing of organ donors, in 1985, when they recognized that HIV could be transmitted through blood transfusion, the US Public Health Service recommends that all organ donors should be screened by HIV antibody testing. So that's put into place. In 2013, NAT is added for targeted screening of increased risk donors. And what had happened in the years prior, in 2007, there actually was a transmission from a donor who was antibody negative to 2 recipients who then turned HIV positive. And that donor was tested retroactively and was NAT positive. So NAT was first incorporated for increased risk donors, so those who might be at increased risk for transmitting HIV or hepatitis. And then in 2020, to make testing of donors more equitable, NAT, in addition to antibody, of course, is now actually universal screening for all organ donors. We actually don't use this indication of increased risk donors anymore because really any donor could be increased risk. Well, in the context of this testing, how are these organs utilized? So organ donors who have positive HIV testing, what happens with them? So pre-2013, pretty much organs from donors, even with suspected false positive, were just discarded or not utilized at all. And then 2013, the HOPE Act was signed into action. So the HIV Organ Policy Equity Act allowed transplantation centers to use HIV positive organs in people with HIV, but this had to be done in a research setting. And so there are a bunch of very specific protocols put into place. I'm just showing a picture of this. You can see Peter Stock there was really one of the pioneering surgeons who first started doing organ transplants in our patients living with HIV. Since then, what does that mean? Unfortunately, this policy is really, really not clear. It actually does not differentiate between HIV infected organs versus HIV test positive organs. And so there's a ton of ambiguity. And as a result, these organs are almost, even if confirmed, or we pretty strongly feel like are false positive, they're shunted to the HOPE kind of program. But as you think about it, like there are actually way more HOPE organs than there are HOPE recipients. So a very large proportion of these organs still get discarded or are not adequately utilized. And there's actually no clear precedent for using even a false positive HIV donor in HIV negative recipients. So that's kind of the background. This just going back to the case, this is all the testing that came back. So the donor comes in one day prior to donation, and I like rush into the hospital and like meet him at 5 p.m. My hope was to actually get a very detailed history. Turns out the very lovely human being. Basically, his story was that he got into organ donation because he had planned to donate a kidney to a close friend who ended up passing before he could donate that kidney. So then he used that kidney. He decided to donate like anonymously his kidney in honor of his friend. And then afterwards, it was such a meaningful experience for him. He decided to proceed with anonymous partial liver donation. As you can imagine, not trivial at all. So I spoke with him for a while. He had 0 risk factors for HIV acquisition. And then I also asked him about risk factors for HIV too, kind of thinking about, is there a possibility that there could be like a negative, a false negative, not even though the differentiation was negative. Also asked about, surreptitious ARV use, none, and he had no symptoms of acute HIV. And then, as you all know, the testing above was confirmed to be consistent with the CDC criteria for negative HIV testing. And so we decided to proceed with donation as an HIV negative donor. And of course, we did arrange additional testing, but none of this testing would be, even talking to the lab, would be able to return prior to the donor going to the OR. So the donor goes to the OR, has an uncomplicated partial liver resection, and then here at UCSF, the antibody antigen and the HIV-1 PCR subsequently returned negative. It's very, very nervous about that. Yeah, so that's the case. Right, and then we're actually trying to use this case at a policy level to advocate when there's time to confirm that there is a true false positive HIV negative donor, then these organs should be used in HIV negative recipients. So we could better, like, because the big picture is, right, too many people on the waiting list, too few organs. All right. I am going to transition. The prior few cases were about kind of our organ transplant patients. And so I'm going to move on and talk a little bit about our heme malignancy stem cell transplant patients. This question is, when is it safe for transplant, specifically when you're thinking about patients with complex infection histories? All right, this is a complicated patient, and I am super happy to go. I'm going to go through the history kind of quickly so we can get to the question. 38-year-old man with HIV and familial HLH. So his HIV was diagnosed in 2019. And he was started on Biktarvy. At that time, he was diagnosed with neurosyphilis. He also had shigellosis, and he also was diagnosed to have visceral KS of the inguinal lymph node and was treated with Doxil. This unfortunate patient then starts, like, despite being on HIV treatment and being suppressed, he starts having symptoms, has multiple admissions for like renal failure, elevated LFTs. While they're figuring this out, they actually switch him over to Juluca. And then a few months later, he is diagnosed with familial HLH. After that, he establishes at UCSF with our heme malignancy program with our stem cell transplanters, and he undergoes a reduced intensity, like haplo stem cell transplant from his father. And that is complicated by some of our kind of typical post-transplant infections, such as strep bacteremia. He also has CMV viremia and is treated with foscarnet and then valganciclovir. Unfortunately, after that, he loses donor engraftment, so his transplant fails. His KS relapses, and he has to be treated with Doxil. He develops BK hemorrhagic cystitis, and This is being managed in the outpatient setting, and he gets really, really depressed, basically stops taking his anti-CMV medications and gets resistant CMV. He also stops taking his HIV medications due to depression. His viral load's up to like 200,000. And I'm his HIV provider. I sent a GeneSure Prime. And so our big picture goal is like, let's get him, like, we need to really prioritize his adherence to his ARVs so we can get him suppressed, so he can get his second transplant. And then what happens? This happens. He comes to the hospital and he is admitted with strep pneumobacteremia, his complicated purpura fulminans, multi-organ failure, and DIC. This is his very prolonged hospital course. So he gets started on ceftriaxone for his strep pneumo, his because his he's viremic with HIV. When he comes in, his ARVs get escalated to Descovy, dolutegravir, and Prescobix when he's in the hospital pending this GeneSure Prime that we sent off in the outpatient setting. He then gets, in the setting of the multi-organ failure and the DIC, he has dry gangrene of his bilateral lower extremities that is complicated by superinfection. There's Pseudomonas, there's steno, there's GNRs, and then most notably there's Scedosporium apiospermum, which is a mold. His GeneSure Prime in the outpatient setting actually is unable to be conducted because he's actually started taking his ARVs, and so we had to send a GeneSure archive. Which resulted. And then afterwards, because of this really, really bad dry gangrene with superinfection involving like the deep muscles, he actually undergoes bilateral BKA. And then he has started on voriconazole, but he is a hypermetabolizer and so requires PPI boosting in order to like try to treat his Scedosporium invasive mold infection. Luckily, his HIV gets suppressed, but we have to switch his ARVs in order to account for drug-drug interactions with his azole. He finally gets stabilized and he's discharged. When can we give him a second stem cell transplant? That's the immediate question, right? Now, never, depends. All right. I feel so 75% of people are saying depends on urgency, and I completely agree. We just decided a later date and see how it goes. All right. So yes, depends on urgency. This is actually one of my patients in clinics. I've been following him closely. Since discharge last summer, he's actually recovering and improving with functionalities. You can see his bilateral BKAs are healing well, and he's actually using prostheses and he's walking around, which for him, I feel like he's gotten a lot more independence and made him feel from a mental health standpoint, like really good for him. When he requires, from a mental health standpoint, he really needs to be doing well in order to participate in his medical care. From an HIV standpoint, he remains suppressed, and I just recently transitioned him to Biktarvy so he can be on a 1-pill regimen, which is helpful for him. The main thing that we've been dealing with is really optimizing his antifungal dosing and levels. As I mentioned before, he's actually a hypermetabolizer of voriconazole. So he, in order to have even close to therapeutic levels, requires 3 times a day dosing of voriconazole at a super high dose plus a PPI, but he is unable to do it 3 times a day. So we had like a very extensive conversation with pharmacogenetics about like what's the maximum dose of voriconazole we can give him at one time. And so right now he is on BID dosing of voriconazole at 600 milligrams plus a PPI for boosting. And then we're actually awaiting a repeat PET CT to assess the extent of his fungal infection prior to proceeding with a second stem cell transplant. And so I'm working really closely with his primary transplanter, Aaron Logan, to kind of make sure that he's, coming in for his appointments, adhering to his medication regimen. Yeah, but we're hoping to get him transplanted in the next few months, actually. All right, so I hope with some of these cases, you can see some of like the complexity and interesting questions that we get over at UCSF Health. My summary statement, summaries from these cases are, of course, organ transplantation is a life-saving treatment for patients with HIV. So we try to make every single effort to move them forward with transplant. But of course, this requires a lot of close attention to their HIV regimen and history to just come up with a plan so it can be conducted as safely as possible. Due to the shortage of organs, it's also crucial to optimize safe use of available donors. We think about this very broadly from a transplant ID standpoint. We try to use as many organs, even if there are infections, as possible, so long as it can be conducted safely. So from the lens of HIV, we'd love to be able to use donors with false positive HIV testing. We have, if we're able to get all those results back, it'd be great to use those organs more broadly. And then finally, in patients with complex HIV and infection histories, the decisions about immunosuppressive therapies are really just require a very personalized approach. There is not one strategy that fits all. And so part of what I love about Transplant ID is we work so closely with our transplanters. And so we come up with a plan, and what's great is everybody's generally really aligned. We all have the same goal. We want to get the patient treated. Yeah. So thank you. Yeah, I feel like I see some, a lot of patients from over here. And so if there are ever any questions, this is my email. I always love chatting about your patients. You know them the best. And so we often collaboration is what gets them forward to transplant.
Thank you so much, Dr. Fung. What questions do people have in the audience? Any? Awesome. I'll do a similar. Maybe I'll start up there this time. Oh yeah, Joe, you want to?
Okay, that was awesome. And I'm glad the legs look better. So that's amazing.
Yeah, everybody, all of our transplant ID group has that patient
yeah,
who's in the
wow.
hospital.
I thought the most interesting thing about the false negative testing was actually the confidentiality issues with the recipient. That even though it was technically an NAT negative, so by CDC guidelines would technically be a negative test, but pending repeat testing, you can't actually. Is that correct that you're not able to tell the recipient potentially that there was a positive test, even if it was a false positive test, for that confidentiality, and therefore, if to go ahead, that it makes potential post-exposure prophylaxis very difficult. For example, let's say the initial screening was negative, but the NAT was still pending at the time of supported transplant, then that would have been more of an issue. But I thought that was a very interesting dynamic as well about the confidentiality issues, but also how that actually can potentially drive that peri-transplant care period. So it was just fascinating to learn about that case.
Yeah, absolutely. Tim, I talked to you and the rest of our group about this. I actually spoke with the leadership at the like the CDC and UNOS level about what we should do about this going forward. So I think the bigger context is that all potential organ transplant recipients sign a very extensive consent before they undergo organ transplantation. That actually already includes infectious risks. We had a discussion like, oh, well, this is a potential, like we think this is false positive, and we're pretty sure it's negative. Do we actually have to do a further consent in case it's HIV positive? And the decision at the UNOS level was actually no, because if this is meeting CDC criteria for a negative organ, then you should move forward as a negative organ. But yeah, I could imagine if that's why I was so nervous. If this came back positive, we all know in this room how unlikely that would be. It would be point whatever percent, but still it's super, super high risk. So there was a lot of we were very, very nervous about that.
Question.
First, I'm really happy for all these patients that they have you and your team as their doctor. I mean, this is really impressive. The thoughtful approach that you guys are taking. I had a question related to the CMV prophylaxis because in both the cases where there was KSHV involved, valganciclovir has some antiviral activity against KSHV as well. I'm wondering when the KS tends to pop up. Is it after you stop primary prophylaxis, or does KSHV become resistant to ganciclovir as CMV did in the other case? And then one last comment to throw out there is that I've been very interested recently in whether subclinical CMV may be contributing to cancer risk in general, in particular infection-related cancer risk in the setting of treated HIV, but even more so in the transplant setting. And I was struck by the high rate of cancer risk in people with HIV who undergo transplant. I wondered, are those infection-related cancers primarily? There's a lot of KS, obviously, but I'm wondering if that's an even greater problem in that population.
Yeah, that's a really great question. I think requires further study. I will say, like in that HOPE data that I presented, there's only been 25 nationally HOPE livers done, and like so those KS and HHV lymphomas, there were only 3 patients. They're in the relatively late period, but I don't know what prophylaxis they got. In liver transplant, most centers do primary prophylaxis where they do get valganciclovir, but we are actually moving more towards like a preemptive approach. And so I think the question is like, what do you do, kind of balancing like the additional potential benefits of antiviral therapy versus like, of course, the goal is to get some CMV immunity, and there's increasing data about how prophylaxis prevents that. Yeah, lots of super interesting questions. Thank you.
Hey, Monica, thank you. That was fantastic. And I'll just second Peter's comment about thank you for caring for these patients. One comment was just in terms of false positives, just the challenge in the PrEP era, particularly long-acting CAB and Truvada usage, just of discerning, is this really a false positive or someone with a negative NAT because they're effectively suppressed on a PrEP regimen. Just one comment to think about.
Absolutely.
It makes it challenging, of course. The question I had as a follow-up somewhat to Peter's, when you showed that slide of the really high, I think it was 25%, the donor positive, recipient positive patients who had higher rates of cancer compared to donor negative, recipient negative. I was just curious, I know the numbers are small, but if there's an ability to tease apart to what extent these are patients where the donor had KS and the immune suppression is leading, for example, or a pre-existing cancer, or is there evidence? I mean, I'm not sure how much HHV screening is done pre-transplant, but whether or not the recipients may have been HHV positive, donor negative, and then the donor develops a subsequent cancer. I'm just curious if that was looked at, like the ways in which those cancers develop.
Yeah, no,
Thanks.
that's a really great. I don't think any of these were donor derived because those are very, very like carefully scrutinized in terms of like that's reported as a transmission. But I don't think there was any baseline screening of HHV status. The comparison is all the recipients are HIV positive, but it's like receiving an HIV positive organ versus an HIV negative organ. The other types of cancers, like outside of KS and the HHV lymphoma, were like parotid cancers, skin cancers, things that I guess there could be EV related cancers as well. But yeah, this is exactly what needs to be, I think, teased out more, and we just don't have the numbers quite yet to do that. Yeah.
Maybe I was going to follow up on Peter's point about the CMV as well, because I don't know, Peter, did you said Aji came from UW and gave a great grand rounds at Parnassus last week about not doing continuous prophylaxis, and at least in liver. I guess kidney is yet to be determined, but that if you treat as you start to see viral loads come up, they actually do better overall, and that's because they develop anti-CMV. These are for donor positive, recipient negative participants, and so one wonders that we have people with HIV where there's a very, very high rate of CMV carriage already in the recipient population, that obviously this may be a very different situation than in your classic D positive R minus type of things as well. Because I don't believe there were people with HIV in Aji's trials? Is that correct? I can't remember. I
No,
don't think there
all
were,
the
right? They were
studies,
all.
HIV is excluded from pretty much every transplant, like dedicated transplant study.
So that's
No.
going to be a big open box, I think,
Yeah.
about in that special population. So,
Yeah.
yeah.
Sure.
Wonderful. Let's give a round of applause for our speakers. Thank you.